So, good morning everyone. So, I'm here to share my experience with the SILK laser surgery. Dr. Raghav has covered most of the theoretical part, so I will not go to that part. So, we have started our SILK in 2025 in the second month of this year. So, my experience, introduction, this system is. As Dr. Raghav has already told, I will not cover the theoretical part. It's a low energy treatment as compared to the other system. This is the just 40 to 90 nanojoule per pulse, and spot size is very small, 1 micron meter, ultra short pulse duration, and ultra fast pulse frequency. So these are the differences with the other system. Though the main system is the Y-convex lenticule, which the Dr. Raghav has already told in the last presentation. So this is our OT, and we are doing this is the vacuum ring placement and docking. Lenticule and side incision formation by Alita femtosecond laser, and gentle incision opening, and first anterior plane dissection. So this is the surgery that we are doing in our OT. So the main feature, this is the video of that, the cyclotorsion. So after flat implantation, we can do the post-docking centration. Like in this slide, you can see that we can, after implantation, we can adjust the parameter. We can adjust the margins with the margins that we have marked with the blue dye. So this is the main feature of this system, that's post-docking centration enable better visual outcome by minimizing higher order aberrations. So how this machine works. So the SILK is going on. Okay. So lenticule and side incision formation, this is the system that provides although I don't have any financial interest, Alita system provides laser with low energy and small spot size, leaving no pulse separation, which lead to continuous tissue resection with minimal residual tissue bridges, and therefore less lenticle manipulation for tissue and ease of lenticle removal by surgeon, leading to less keratocyte activation and reduced immune response, resulting in a fast recovery. So this is how we remove this is the dissection. The meniscus sign is very important. First we go into the anterior plane, then into the posterior plane. This is the meniscus sign. This is very important to differentiate between the anterior and the posterior plane of the lenticule. So the biconvex shaped lenticule, the importance of this is the less collagen fiber, it expected to cut the less collagen fibers in the peripheral cornea by cutting deeper into the stroma, thereby producing less opaque bubble layer and better preserving corneal biomechanical strength, and minimal disruption of the peripheral collagen network in the anterior stroma, constituting approximately 60% of the total corneal tensile strength. So this is we are dissecting the posterior part of the cornea, lenticule. Energy optimization is very important. Like in the initial cases, we have the tough dissection, but in the last few cases, the dissection is so smooth, and it take only, I think, few seconds to remove the lenticule starting from the start of the procedure. So this is the importance of the biconvex design, that edges of the lenticule are more posterior in the cornea compared to the planoconvex, and this area has low density collagen fiber and corneal nerve, which supports faster nerve regeneration and healing. So this is more theoretical. You can see why it is more good. So there are the few complications that the complications arises when startledly we have a patient come with number of minus 1.75. I asked him to go for the LASIK, but he said no, he will go for SILK only. So we did SILK, and this is the SILK OD treatment summary. These are the post-operative pictures. Everything seems to be good, but when we started, because in the thin lenticule, the wrong plane dissection is the most common complication that happens. So first we have to dissect the anterior plane, but I was thinking that I am in the interior plane, but unfortunately I was in the posterior plane. So when I have got this, that the anterior part plane is still there, so I tried to get into the anterior plane, but which become difficult. So I'm not getting that how to enter, and so many attempts just to find out where is my opening of the anterior plane. So always this is the thing that, so I tried to hold the anterior lip with the forceps and tried again, but so this is very important. The entry into the anterior plane first is very important. It is mostly happen in the thin lenticule when you are doing with the surgery of a very small number. So this is how I entered the anterior plane, and rest is everything fine. When you get the plane, then everything is good. So this is how we remove the lenticule. Only few. This is another complication, suction loss, although we have not any suction loss so far. So there are the little complications, two more complications. I will take only few seconds more. So this is the folding of the lenticule. This always happens when you deal with the thin lenticule, or you don't have the fulcrum you didn't left from the one side, and the overconfidence is the second reason. When you say that it is just a 10 seconds game, so when you start in hurry but something, this folding happens, but can easily be taken out, these folding. So last complication, so you can see that I have insected from the posterior plane and then remove the lenticule. So this is the lenticule tear, another complication. So this happens with the inadequate ablations and with the OBL. So you can see the part of the lenticule is inside the pocket, and the tear is also there. I tried to remove it, but the little force. Then on the second day, I have inspected the lenticule, that there is a retained lenticule, but everything was good. And on the second day OCT, we didn't found any retained lenticule into the pocket. So you can see that everything is fine. So complications, so these are for the beginners, the complications are more likely to rise during the initial learning phase, with the majority attributed to lenticule dissection and extraction challenges. More technically challenging, like the new surgeons, low myopia, complicated orbital anatomy, high astigmatism, these are the patients to be avoided. So in my experience, SILK is highly successful, consistent, safe and effective treatment of myopic refractive error with or without astigmatism, and easy lenticule removal and fast visual recovery were demonstrated with no serious adverse events, although mild corneal edema, peripheral corneal scarring, hemorrhage were noticed in few cases, which subsides at the end of the first post-operative week. We did, in last few months, we did 206 eyes, 206 eyes. With SILK, and complications are more likely to arise during initial learning phase, and results are excellent and after proper energy optimization and surgical skills. Thank you so much.
Thank you so much. I think the technology keeps on improving. While the LASIK has matured a lot, but smile technology is always progressing now and improving a lot. And still we require customization treatment, hyperopic treatment. That may be in the pipeline. I think that will come in the future.